And with us we have today Dr. Sitesh Roy, an eminent allergist. He is a US board certified allergist, immunologist and asthma specialist. He is the founder of Dr. Roy Health Solutions Clinic in Mumbai. Dr. Roy has done his fellowship in allergy and immunology at the National Jewish Medical and Research Center, University of Colorado School of Medicine in Denver. Sir has also been listed as the best doctors in America in 2005, 2006, 2007, 2008, 2009, 2010, 2011 and 2012, and Guide to the America's Top Physicians from 2005 to 2010. He is also the author of original articles and publications for leading medical journals internationally. Sir, I would now like to invite you for your talk, please.
A very good afternoon to all of you. I wanted to take this opportunity to just go over the field of allergy with you all and give you all an idea of what we are up against and what we have available. Because as has been mentioned, this is a very common problem. Either we ourselves at some point in our life, or a family member, or a friend, or a colleague, we will come across who has one of a list of these problems that I will just go over. So without too much further ado, we are talking about an immune dysregulation. So our immune system is really designed to distinguish self from non-self. What's ours and what is not ours. Whether it's a cancer cell that's forming in the body and the body sees it that it's not ours and rejects it and clears it, to a virus, to a bacteria, to a parasite. But when it starts reacting towards things that it should not react towards, what we call hypersensitivity, there begins the problem with allergy. Allergy is one form of hypersensitivity reaction of the immune system. There are 4 such mechanisms, and this is what we call an intolerance mechanism, where the body is fighting against a dust mite or a pollen or a tree or a grass weed pollen. When we look at the origin of this word, it actually comes from the Greek word meaning allos and ergos. It means an altered reaction or a changed reaction. So imagine a small baby who's drinking milk. That baby's body is supposed to accept the milk, digest the milk, assimilate the milk, and respond to its proteins like it knows it for millions of years. But something goes wrong in the body, which we'll talk about what the different mechanisms are briefly, and its body decides that that milk protein, which is a ubiquitous protein, a safe protein, is now something that it does not like and fights against. And there begins milk allergy. I have seen babies who are a few days old developing milk allergy, or a little bit later to other foods that the baby has never even tasted yet, but it's coming through the mother's breast milk, suggesting that allergies begin very early in life. In fact, some people believe that it even starts in utero. Babies can get sensitized because it has been shown on cord blood. So this is an altered reaction that can begin very early, and the reality is it can come up at any point in life. So we have adults who may have had a food their whole life, and one fine day they're in the hospital after eating that same food, suggesting that this is a phenomenon that can get dysregulated or imbalanced, unfortunately, at any point in life. So it's a substance that's in the wrong place at the wrong time in the wrong situation, and you get an altered reaction. So that's allergy for you in short. Hypersensitivity means reacting to something that is otherwise innocuous and harmless. It's an overzealous response. It's self-damaging in nature, as we can expect. Means if you're inhaling something 3 months out of the year that's a pollen in the air and your body fights against it, it's obviously going to cause damage and harm in the body. And it's due to a failed balance. This balance is between something called the Th1 or the type 1 and the type 2 immunity in our body. Type 1 is critical for fighting off infections of certain types, and type 2 is important for fighting off primarily viral and parasitic infections. But when the body starts responding a type 2 reaction to things that are proteins in our environment, maybe a dust mite allergen we can't even see, or a food allergen that we consume on a daily basis, lo and behold, we now have a hypersensitivity or an allergy situation that's problematic. This is the antibody. Now, this word culprit antibody is unfortunately something that I don't like using, but it is used in all presentations, IgE. That's the substance that we measure when we are doing a scratch test or a blood test. We are measuring this IgE antibody that's present in the skin on mast cells. It's present in our blood circulating. And it's this substance that when it is formed towards a protein that someone is allergic to, it goes and coats the mast cells, and next time you're exposed to that protein, they cross-link each other and they release these substances, which depending on which organ in the body is affected can give you a wide variety of symptoms, and we'll come across that in a little bit. But IgE was given to us by God, the Lord, whatever you believe in, for a reason. It's meant to fight off viruses and parasites. It has a good defined reason for being there in our body. Problem is when it gets converted into the bad guy, we then start calling it the culprit. And when it gets really bad, that's when you have anaphylaxis, which is where someone eats a food, like for example, many of you all have seen in movies or have known someone who may have eaten seafood or eaten a nut and landed up in the hospital, sometimes in the ICU. That's anaphylaxis for you, a very severe allergic reaction. I'll give you all a moment to read some of these things, but really there are hundreds and hundreds of cartoons that are there on the internet in relation to allergies. Like this one where this lady who's known as Auntie Acid, as you all probably well know, is saying that this is, you know, it's like saying season's greetings. This is sneezing's greetings when it comes fall or spring, especially in areas where there are defined seasons. Now we do have defined seasons, but being a tropical country, our seasons tend to blend or merge into each other. But we do see some clarity in how people transition from the cold weather to the hot weather to the monsoon weather and then into the cold weather again and get different allergies. Imagine a snowman who can't have a carrot. So allergies, those can be a point of fun, is really not a joke, because when we look at the scope of this problem, we are talking, it is estimated that if you take right from a simple cutaneous skin allergic reaction, let's say to a cosmetic or to a perfume or to a fragrance or to a soap, all the way to eczema, to food allergies, to drug allergies, to insect venom allergies, to nasal allergies, which is allergic rhinitis, to asthma, it is estimated that 30 to 40% people on the face of this earth at some point in their life will be having something that's related to a hypersensitivity reaction. That's a huge number. And of that, at any given time, for example, in India, it's estimated that about, as Ali was mentioning, about 20% of the population is sensitized. Is it allergic or not is a secondary question. You may have a positive skin test, but not symptoms. Symptoms come when you are actually allergic. And we'll talk about that a little later. But it's a very high burden that we are talking about. 25 crore Indians just for respiratory allergies is what we're talking about. And a high proportion of these begin very early, at a young age. Like I said, babies with food allergies, young children who are wheezing, they're going back and forth for taking nebulizers and inhalers, and asthma beginning in the second, third, fourth year of life. It's called the atopic march. Starts with eczema, itchy rashes, cheeks, arms, body. Next thing you know, there's food allergy or environmental allergy. Next thing you know, they're sneezing, they're wheezing, and before you know it, they have the entire spectrum of the disease. They may outgrow the skin allergies, but then continue to have the respiratory allergies. So that's called the atopic march in short. What's behind all this? It's well accepted that this is a multifactorial problem. Stress, when I say stress, I'm not just talking about mental stress. There are physical stressors, chemical stressors, emotional, psychological stressors, and then if you go steps further, these are the stressors we normally look at. But then beyond that, there are things like celestial stressors, astral stressors, spiritual stressors. We won't get into those today, except at the very end, since it's a passion for me. But this stress is at the root of why our immune system becomes dysregulated. When I say chemical stressor, eating the wrong food at the wrong time in the wrong way is a chemical stress for the body. When I say physical stressor, you work too hard, don't eat on time, body goes through stress, stress for the body, it can dysregulate. Mental stress, we all understand, go through it every single day. And then there's diet, lifestyle, environmental and genetic factors that follow after it. When we look at the scope just worldwide, eczema 100 crores, nasal allergy 50 crores, asthma 30 crores. I have not even listed these because it's very hard to estimate, but food allergies, for example, in India, in the pediatric age range between 3 to 5%. When you look at the Western world, allergies are more of a westernized diet, lifestyle disease, and we are becoming more and more westernized with each passing day. Hence, our levels of allergies are increasing 200 to 250%. Okay, that's more than double within 2 decades in India. When I was training as a medical student about 25 years ago, I remember having one wheezer on the ward, one child who would be on a nebulizer. Today, when I walk into the wards to round with my friends who are in government hospitals, more than half the ward sometimes is filled with kids who are wheezing. That's not just a thing that has occurred overnight. It's a process, and it will continue to rise. We have not yet reached the top of the world as the most allergic community. We still have the US, the UK, Australia, New Zealand, those are still at the top, but India is really catching up like this with each passing day. And at the bottom, as you can see here, there's the life-threatening anaphylaxis. Just again, a representation of really the degree of problem. We're talking about 1.2 billion people, and we're talking about 400 million who have a burden of disease. These are the most common allergens that are there in our environment. There are the house dust mites, there are the pollen, the roaches, the animal dander, and the mold. Of this, the house dust mite and the pollen probably cover about 80%, 85% I would say of what we see. And the remainder is covered by the other allergens. We don't see as much pet dander allergy as we did in the West, as in when I was practicing in the US. But I am seeing more and more of it with each passing day. And not just to the common pets like cats and dogs that we see, but also to gerbils and hamsters and rabbits and horses and cows, you name it, anything that has fur on it, and it's causing a sensitization these days. Which means the problem is not with these animals, the problem is with our immune system that does not know how to handle things that it could handle before. And that's where the whole theory of biodiversity comes in. Our immune system was used to a very biodiverse universe before, which now, by living in closed spaces, enclosed homes, very little circulation, not getting into the dirt and dust, and living lives as we did in our rural environments when we were probably 500,000 years before, we have now cut out the biodiversity. The immune system that used to be able to tolerate everything now starts seeing things as a problem, and the problem begins. So people ask me, what is the risk of becoming allergic? Population risk, conservative estimates, 5 to 15% chance that anyone can become allergic, okay, anyone. If they have one sibling, one brother or sister who has an allergy, that risk goes up to 25 to 35%. If there's one parent, between 20 to 40%. If you have both parents who are allergic, the risk goes up to 40 to 70%. And if both parents are allergic with the same symptoms, that means both mother and father have nasal allergies, or both mother and father have asthma, the chance that the child will have a problem goes up to almost 80%. Suggesting that as we are seeing younger and younger babies who are growing up allergic, their kids are going to have a much higher risk of becoming allergic than the new onset cases we are seeing now. So you can only imagine where this thing is going to escalate in the next 3 decades as these people grow up and have kids of their own. This is just a conservative estimate of the cost involved with allergic diseases in different parts of the world collected by the World Allergy Organization, and as you can see, the numbers go into billions of dollars, whether it's Australia, Finland, Korea, Israel, Mexico, USA. You see the number here, 20.9 billion US dollars. This is based on not just the person themselves being sick and having to take medicines or go to the doctor or go to the hospital, but also based on how much time they lose from work, how much they lose their focus, attention, and clarity in the work that they're doing, so their productivity goes down, how much the parents lose their work because the kids are sick at home, how many days of school is being missed by the child and his education and other work is getting affected. The list is endless of what it does. And so what exactly are these allergic reactions that we have to be aware of? Depending on the organ system that's involved, okay, Whether it's with skin, you can have itchy rashes, what is called eczema. There's a typical pattern that develops in children. As they get older, adults may only have it on hands and feet. It may not be on the whole body like a child does. If you look at one step further to the nose, then you're talking about sneezing, runny nose, nasal congestion, blockage. There are something called sneezers and blockers that is used by the ENT folks, the ear, nose, throat surgeons. They call them the sneezers and the blockers, and then there are ones who have both. And then this leads to ear infections, sinusitis, headaches, sleep disordered breathing, obstructive sleep apnea. The list is endless on how that list grows from there on. If you talk about one step further lower into the airway, you're talking about wheezing, coughing, tightness in the chest, breathlessness, difficulty doing activities, and sometimes chest pain. I've had patients who have been later on diagnosed as asthma with us, who have been going repeatedly to the emergency room thinking that they were having a heart attack. And every time the ECG is normal, their CPK-MBs are normal, enzymes are normal, ultimately they come to us, we ask a few questions, do a simple lung function test, lo and behold, it is full-blown asthma. Chest pain is the only, people think you have to wheeze, you have to become breathless to have asthma. No, you may have a cough that is not going away and it could be asthma. You do not need to wheeze. You do not need to have shortness of breath to diagnose asthma. So a very high level of suspicion is required. So that's inhalation part for you. Ingestion, medications, foods, we very well know food allergies can present as simple abdominal discomfort, vomiting, nausea, can come up as hives and rashes on the body, can come up as diarrhea and indigestion. There can be all kinds of manifestations of food allergies that are seen. Then there are the insect stings, okay? I've had people come from all over India to me to diagnose these, because diagnosing it itself can sometimes be very tricky, and then the immunotherapy that we do to it is even more complicated at times. Medication allergies, the most common reason for an adverse reaction in a hospital is actually a drug reaction. And so a very, very common problem. And then you have all the contact allergies which come in direct contact, the typical latex allergy that you all have heard about. So what are the perceptions about allergy in the common community these days? It's bothersome, everyone agrees. It drains the energy, people are tired, fatigued, don't have the full energy level, not the focus, the attention, sleep gets affected, work gets affected. All right, episodic disease comes and goes, okay? It's an unimportant issue for most people, including physicians. They believe in treating it when the problem is there, forgetting about it after it's gone. When in reality, this is a chronic disease. A disease that is with the person at least for a few years, if not sometimes for a lifetime. I've had kids who started out at 6 months and 1 year of age who are now coming to me in their 40s and 50s and have never had a good 3 or 4 months in their whole life. And then it's non-significant in the big picture, because if it doesn't kill you, it makes you stronger, right? That's what we all say. But if it doesn't kill you, it can also make you miserable sometimes. And that is what allergies do. People decide to just live with it, when in reality, allergies are really life-altering, is the way we look at it. This is just the impact of nasal allergies that can occur in a person. Right from asthma, atopic dermatitis, these are all the comorbid conditions that can occur. Decreased quality of life, sleep disorders, learning attention impairment, mouth breathing, dental occlusion, dental malocclusion, so much so that you can see every organ system in the body affected due to a simple nasal allergy. It has been shown. And so poor performance and reduced quality of life become an issue. So looking at all this, it becomes very clear that identifying it early and doing something about it early is a requirement today's day and age. And what enables this is being able to identify early if it's a child, and then instituting avoidance, treatment, and where recommended immunotherapy. So that brings us to the diagnostic and therapeutic part of what we do as allergists. So when a case comes with us with, let's say, a skin problem or a respiratory problem, or a gastrointestinal problem. So as you can see, I have a referral base that comes all the way from general practitioners to every specialist that you can think of. And it's because as an immunologist, we see a cross of many fields that interface with an allergist, because these things can affect any system in the body. And so when we look at allergy diagnosis in the 21st century, we are looking at obviously the clinical. So when you go to a physician, the physician has to have the awareness to know that they are dealing with an allergy. Otherwise, they'll tell you have a common cold. Take an antibiotic, take a fever medication. You'll be better in 7 days if you take the medicine. You'll be better in a week if you don't take the medicine. That's the secret we doctors use in our practice. We are taught that when we are medical students. For a cold, if you treat it, it's better in a week. If you don't treat it, it's better in 7 days. Majority of them, okay? But then if you keep going back, there's a problem. So either you have an immune system that's not working right, you'll still have to see someone like me, or you have an allergy, you'll have to still see someone like me. I'm not saying me, allergist, immunologist, specialist, and take it further. So clinical diagnosis, good history, key. And then you come to the allergy skin testing, blood testing, patch testing is more for skin. These are challenges, like this is a food challenge. We give the person small amounts of food in a controlled environment and check them at regular intervals to see if they're having a reaction. This is an example of what the blood tests are, some of the machines that are very much available here in Mumbai and now across the country, which can do on blood tests for anywhere up to 200 allergies, different food, environment, insect, etc., etc. But obviously skin test still remains the gold standard of test. The skin test solutions, you all will get first-hand chance. Some of you all have actually said that you all are allergic, and will we be doing? We'll do okay, and we'll be doing it, doing some tests on you all, so you all will get first-hand idea about what this is. We do the typical skin prick test. This is still considered the gold standard worldwide for diagnosing allergies. And what happens in this is a very simple process of placing the antigen on the skin, pricking through it, waiting about 15 minutes and looking at the reaction with a positive and a negative control. Results are within 20 minutes. You go for a blood test, it takes 3 to 5 days turnaround time to diagnose the allergy. Here you have what I call, in my field, instant gratification. Patients are happy, parents are happy, we are happy, we know exactly what's going on. So still worldwide allergists say that skin test is the gold standard for diagnosis of allergy. Blood tests come as a secondary option. If you can't test a person, they don't want to go through multiple pricks, they are afraid, they have bad skin that you can't test on, they can't stop their medicines which are required to be stopped for allergy skin testing. Those are some of the situations in which we do the blood test. And this is a typical reaction that you can see here, where we see something called wheel and flare reactions. I don't know how well that is projecting here due to the light in the room, but it's a very obvious reaction, but can be pretty small at times, millimeter sizes. Even for very young children with very thin skin, we do not actually have to remove blood when we do the test. It can be done in a bloodless manner. And the pain reduction is a big advantage. Patients gain more confidence. So as it is called here, a minimally invasive needle proves both the safety and the efficacy of our therapies over time. There are nasal provocation tests. So sometimes we have people who have very classic allergy symptoms, but all the tests we do, skin or blood, everything is negative. It's because they have something called a local allergy just in their nose. And so we actually have to squirt the allergen up their nose and do some special test called rhinomanometry, and we can identify who those people are. And that can make a world of difference for their treatment. So there is something called nasal provocation test, and then there's immunotherapy, in which we actually desensitize the patient from that which they are allergic to. So one is you avoid the allergen. Now I had a gentleman now who's a farmer by profession. He traveled about 1,000 kilometers to come see me because there was no one who was willing to do immunotherapy for him. He was stung by a bee. The first time he got stung, he had a reaction about 40 minutes later. The second time he got stung by a bee, he had a reaction in 15 minutes. The third time he got stung, he had a reaction in 4 minutes. And if he hadn't been close to a hospital, he would have been pronounced dead. Now imagine a farmer who can't leave his profession, who can't live in a place where there are no stinging and flying insects, has to now live with this fear. Literally this guy, when he came to me, he would come all covered up with all kinds of things on his body, so because he didn't know where the next sting would come from. So or having a food allergy where you're traveling the world, you want to do world travel, but you don't know who might add peanut in your gravy when you're trying to tell them that you're peanut allergic. So sometimes it can be very hard to avoid, and so being able to desensitize people becomes very important. Medications and allergy education, we all understand, is important. Controlling the environmental allergens, I won't go into too much detail with regards to house dust mite, which usually if we take 100 allergic people in India, 60 to 70% of them will be allergic to house dust mite, okay? Some will say 40, some will say 50. In my practice, I see 60 to 70% sensitization. And so special covers that are put, encasings on the mattress and pillow that can really reduce the day-to-day exposure to these dust mite allergens in the environment. Just a few words on immunotherapy, because this is also 11 when the first published article is there on immunotherapy. There have been over 800 to 1,000 articles showing that you can desensitize people by giving them the same thing either through injection or orally, so that their immunity builds up, their resistance power builds up, whatever you want to call it, their tolerance builds up, and that they don't have reactions to those things. It can reduce symptoms, it can be steroid sparing, it can reduce flare-ups, it can alter the course. So kids who have nasal allergies go on to develop asthma. They have a 60%, 50% chance of doing that. Whereas the population risk of a child developing asthma is about 3 to 5%. So just having nasal allergy risk goes up to 40, 50%. That conversion can be altered if you do immunotherapy on right time. So very powerful therapy. It's safe and efficacious as long as it's done as per guidelines. This is what subcutaneous immunotherapy looks like. Looks scary, but actually is not that much. These are tool or sublingual immunotherapy, where there are drops taken under the tongue, and with progressive dosing, you build up again your tolerance or resistance, stop adversely reacting to that substance, your symptoms go away, God willing, your disease can go away. So it's the closest we can come to cure when it comes to allergic diseases. So there is definite hope. We just have to become more vigilant. We have to create the awareness both amongst general public and amongst physicians, and we have to take the right step at the right time. People ask me, is there a way to prevent allergies? Okay, that's a very big topic, probably a few hours by itself. But it's the same rule for all diseases, right? Eat, exercise regularly, and reduce your stress levels. This applies for heart disease, for diabetes, for arthritis, for cancer, you name a disease, the basic 3 protocols: eat, exercise, reduce your stress, meditate, whatever you want to say. So with that, I'll just go into one quick thing. I wrote the first chapter on stress and allergic diseases in the textbook of Psychoneuroimmunology, which was published in 2010. The textbook had already had 3 editions. This is this fat book with 2 volumes this size, okay? And it had never had a chapter on stress and allergic diseases. So with Dr. Galen Marshall, who was then my mentor, we wrote the first textbook. It was about 28 pages long, of a big book, okay? And I'm giving you the gist of it, what I realized from it. All stress is not bad. There is something called eustress, which makes you sharp, focused, accurate, go-getter, okay? That's good. You need it to perform and do well in life. That's called eustress. And then there is something called distress. When it goes out of hand, you go crazy. You don't know when to stop. You don't eat on time. You don't sleep on time. You constantly think of work, or you have other forms of stress in family or relationships or whatever it might be, financial, and you just go crazy. The distress is the problem. So when people talk about stress management, you don't really want to manage stress. You manage money, you manage finances, you don't manage stress. You handle stress. And it's all about being able to handle stress properly. And for that, when we made a chart in this textbook of how stress plays in, we put stress here because it directly impacts the immune system, and we have research. We took medical students when they were finished with their exam and when they were about to give their exam, and we tested them, and what we found is right before they gave their exams, all their allergy symptoms skyrocketed, and along with it, their asthma was skyrocketing if they had it, and all the cells in their body that release the bad chemicals that give you the symptoms of asthma and allergy were all at a high level, and then their exam got over, boom. Now imagine a deadline at work, a target to meet, a wedding in the family. It's just every day, right? Just traveling from home to work, stress. And so in that, my journey, this is just part of my journey that I like to share wherever I go. About 19 years ago, I made this connection, and I started looking at Reiki, pranic healing, transcendental meditation, yoga, pranayam, diet, lifestyle, everything. And I realized that many of these pathways are incomplete pathways. So with a group of like-minded people, we started actually doing meditation and healing seminars, which range from 2 hours to 2 days and eventually up to 10 days, depending on how deeply a person wants to, as I said, handle and manage their own life, rather than getting lost in what is happening around them, drawn into every next stressor that comes in. So this is one example of a seminar that we have. We call it Happy Living. And you see up here I write, happiness is not a destination, rather it's a way of life. And it's a training which I did not get when I was in medical school. Though I was a doctor and I see a lot of stress from a lot of people and they come and dump it on me every day and go. As you can imagine, right? Here's my problem, you solve it. But there are certain things that I realize that if I manage correctly myself, I can help them better without absorbing their stress and then translating it into problems in life. So wherever I go, I tell my physician friends, physician, heal thyself. If you read this, it's healthy self. These are comprehensive stress reduction and life enhancing courses. If you all are interested in something like this, I'll be happy to talk to you all. But I believe that if this thing can be done from younger and younger ages, we will reverse the tide of many diseases. I'm not just talking allergic disease. And this has to go back to our roots. Our ancient roots are very, very powerful when it comes to diet, lifestyle, and understanding the connection between mind, body, and spirit, from where imbalances arise and disease begins. Every disease begins first here and then comes on the body. And with that, I'll end my lecture. Be happy to take any questions. We will be having some demos later. Any of you all have experienced anything personally or in friends, family, colleagues, or anything I said here that you all have questions about, I'll be happy to take it now.
I'm basically from North India, so I realized that the onset of winter season I start coughing, and it's a continuous coughing, so I have to take anti-allergic medicines, and it doesn't go till the season ends. Okay, so even after a lot of medication. So, what should I do? Even here I have realized of late that during change of season, maybe in the month of December, January, I feel the same thing. So what should I do and how could I avoid this?
So the simple answer is you should come see me.
Okay.
But I'll tell you the longer answer. Today we're going to do some allergy testing. Let's test you for allergies. There's a very good chance, there's a very common phenomenon for people who have not very high level but a low level of dust mite sensitivity. Now understand this funny or interesting phenomenon that occurs. Dust mites are indoor allergens. They live in our mattress, in our pillows, in our sofas, in our curtains, in our carpets, in our rugs. They never disturb us. They've been around us since millions of years. This is the most likely allergen you're suffering from. That's what I'm telling. They eat dead skin that falls off our body. Okay? When they die, they don't come out, they don't disturb us. They die, they become dust. That dust we inhale. Now what typically happens during the winter months? It gets colder. We close our windows and doors because it's chilly. The indoor allergen load increases. The second thing that happens, the dust mites love heat and humidity. When it gets cold, humidity levels drop drastically. There is only 1 month in the whole year. I keep a hygrometer in my house. I've done this since I was in US because I have a very great interest in environment, pollution. I do extensive lectures and research on that. I'll actually be going to a World Congress in Singapore representing India on air pollution and its impact on allergic rhinitis in May. But it's very interesting that in the month of January, February, we have the lowest humidity levels in Mumbai. Though we are living right on the coast, okay, means you would expect that humidity comes in all the time, right? So low humidity, less heat, they love heat, okay, they die. More of them die than they die other times of the year. And you close your home, suddenly the dust mite levels rise. You spend more time indoors, especially in North India when it's cold. You're exposed to more allergen, you start coughing or sneezing or having runny nose. You may actually have some symptoms all year round. So even if you visit me now, I would do a lung function test on you. Chances are you have what we call cough variant asthma, which is also an allergically driven disease, which is why anti-allergics help you. And so if we were to identify your dust mite allergy, give you the right treatment year round, you would not have a flare-up in winter. And if you truly were sensitized, you could actually do immunotherapy, desensitize yourself, and be free of this disease for the rest of your life. Now, besides this, there are many other reasons why a person can get sick in winter, but the pattern you're describing is classic for house dust mite allergy.
It's like Seretide, Fluorocort. These are being taken as inhalers, either from oral or from the nasal, to attempt immediately for any allergy reaction for breathing. But when you take immunotherapy, this is, I believe, it goes into the bloodstream. What is the time of getting the person desensitized? Is it immediate? Is it?
So, medications generally start effect within 24 hours, peak their effect in allergic diseases, especially nasal or inhaled corticosteroids, which is what these classes are, work within 4 to 6 weeks, they reach their peak. Immunotherapy, you have to remember, is not an immediate solution for allergies. So we do pharmacotherapy with immunotherapy, generally within 3 to 6 months, max a year, person has enough relief that they can start reducing their medicines, between 3 months to 1 year. The duration is minimum 3 years, maximum 5 years for immunotherapy. But remember that if you're doing injectable immunotherapy, for example, you're taking an injection once in 6 weeks, once you're at maintenance. So about 8 times a year you have to go see your physician, take the injection, wait about half an hour and you're done. If you're doing the sublingual, the oral immunotherapy, you're doing it at home. You don't even need to see them that often sometimes. But oral immunotherapy is a little slower, dosing is a little bit more variable, but both are good options for treatment. So medications will work quick, but work only as long as you take them. Immunotherapy works slow, but will continue to work for 5, 10, 15, 20, 25, 30 years after you've stopped immunotherapy, if you're in the category of people who are complete responders. If you're partial responders, sometimes there can be a little recurrence after a few years, but never ever to the level that the disease was before the onset of immunotherapy. So it permanently changes the disease, even after it's done. Does that answer your question?
Yeah. Another question is, we take normally antihistamines like cetirizine. So what is the clearance of this drug in the bloodstream?
So a typical what we call second or third generation non-sedating antihistamine. Now while I'm using non-sedating, about 10% people who take cetirizine feel drowsy. But compared to Benadryl where 50% people feel drowsy, it's a non-sedating antihistamine. Its clearance and half-life in the blood is anywhere between 72 hours, 48 to 72 hours, which means it stays in the system for that long. But its clinical effect may not last that long. There may be a lot of people who have to dose it within 24 hours. But in the system, like when we have to do allergy testing, we tell people to stop antihistamines for 3 days. And medicines like Allegra, fexofenadine, can have a clearance of up to 7 days in the system. There are some older generation antihistamines that were up to 10 days. And then there are what is called the tricyclic antidepressants, which are a class of drugs used for depression, which can linger in your system for up to 14 days and they can interfere with the allergy testing. So it just depends, but this drug about 2 to 3 days is what it stays in the system. And if you look at total clearance, it's even longer. I'm talking where all its effects will be gone from the body.
You just made a mention regarding cetirizine, sir, right? So very often we take cetirizine for sneezing. Now we say ki you take levocetirizine, which is non-sedative. Now what happens for me? Levocetirizine is like non-sedative. It works. I doesn't get kind of sleep. But for my brother, whenever he takes while driving, often he comes across such problem like sneezing. So whenever we give levocetirizine to him, he gets some kind of sedation. So how do I explain it? You know, the levocetirizine, the drug, levo form is meant for non-sedation as such. But few of the population, you know, exactly wherein that doesn't work.
I mean, with cetirizine and the degree of sedation that is seen with levocetirizine is actually few % apart. It's not very different. But what you have to remember is every human being is unique by themselves. their digestion, their absorption, their clearance of the drug varies. Also, the level of, that's why I tell you it is not one science, it's multiple sciences. If your brother is the type of person who chronically lives in sleep deprivation or high stress, he will have more sedation with levocetirizine than maybe you do. Such as, I'm giving one example, like that there are 50 processes that we know as allergists, that when we ask people, we realize, okay, this person is at higher risk of getting sedated. The percentage is 10. You have to remember one thing, whenever a drug says that there is a 5% chance of this happening, when you give it to an individual, he does not know whether he's in the 5% or the 95%, right? He could be either ways. For him, it's a 100% chance. So for him, sedation with levocetirizine is a 100% occurrence and event. That's why I say sometimes this becomes I wouldn't call it a marketing gimmick, but it becomes an issue because patients expect something because they read something and they don't get it. But at the same time, the company is not trying to tell them that it is totally non-sedating. Like I have people where Allegra has a federal aviation approval for pilots to fly a plane with fexofenadine in America. I have patients who get drowsy with fexofenadine, confirmed.
Okay.
And that's why I say every human being is unique. The future of pharmacotherapy, the future of pharma is in individualized medicine, where we can actually study the genetics of the person and know whether aspirin will cause bleeding in this person's stomach and it won't cause bleeding in this person's stomach. Whether this cancer drug will work for this person or it won't work for this person. And imagine highly customized, individualized medicine was being practiced in this very land, India, 10,000 years ago by our Rishi Muni. Because every person didn't get the same formula when they went to them for a problem. They got a different mix of herbs, a different mix of formulations. We were 10,000 years ahead of where modern medicine is now reaching in the last 40 years. So there is a blending that needs to occur of this ancient and modern science, and it needs to be followed, and every individual is unique, and your genetics and your brother's genetics, your environment, your brother's environment, your stress, your brother's stress, your diet, your brother's diet is all different. So the same drug causes a different response in both of y'all. That's a long-winded answer to a short question, but a very important question, because this applies to many drugs that people take out there and run into problems.
Thanks a lot.
Hi. Does immunotherapy work for all types of allergies, including allergies caused by medication?
So very good question. We do immunotherapy for environmental allergens, what we call aeroallergens primarily. Immunotherapy can be done for insect venom allergies, and it is highly effective, 99% plus success rate, whereas for aeroallergens it's around 80-85% the success rate. When it comes to food allergies, we really can't do injectable immunotherapy for foods ever. There are people in India who do it. It is not right, it is risky, it is not recommended. There is something called oral desensitization that can be done to food allergies. We do it only in the severest of severe cases where avoiding the food is very difficult. And there are protocols to how we desensitize people. Like I had a young boy, father was a pilot, mother was a chartered accountant in the US. The kid was allergic to every nut that you can imagine. Peanuts, walnut, cashew, almond, hazelnut, Brazil nut, pistachio, everything. Means if it would just touch his tongue, he would be in the ICU. They took a decision that this was not the way they were going to lead their life, nor their kid would lead their life. They approached me and my partner for a desensitization protocol, which is considered experimental. I'm being very clear about it. There's no formal way to do it. There are protocols for it. It took us 2 years to desensitize that boy, but today he eats a cup full of mixed nuts every morning, and he'll have to do that for the rest of his life. That's his immunotherapy. But it took us 2 years to get him till there. And we had to do it for each single nut separately, then combine them together, and ultimately he reached that stage. But they're happy, the kid's happy, he doesn't live in constant fear that the next little cookie or cake or something else he eats will put him in the hospital. Last, insulin is the drug of choice for it. penicillin allergy is one of the most common drug allergies. If we get a case of a patient who's syphilis and positive and does not have any drug that we can give them other than penicillin, we actually admit them to the hospital and do what is called a graded challenge desensitization to the drug. So drugs also can be desensitized. I've done desensitizations to insulin, where a person needs insulin but is allergic to insulin. Imagine what a conundrum of life. Means a hormone that you can't live without, because there used to be something called porcine insulin before, which came partly, it was pork proteins in it. And we had to desensitize them to that insulin so that they could live. It has been done for all kinds of drugs. It has been done for painkillers, aspirin, naproxen, ibuprofen. We have desensitization protocols to each of these. So, not the way I showed you, but desensitization is possible to most agents that we can think of, but not to all. I can promise you that. There are certain types of drug reactions for which even thinking desensitization is wrong. Doing it is very, very far from right.
But there's hope for people with peanut allergies, right?
Absolutely, absolutely, 100%.
That's good.
But the path is long, the path is tedious, but there is absolutely, means, I'm a strong believer as a physician, and also it goes to partly what I've put things like this up here. I believe that if God gives a problem, He gives a solution with it. He never just gives you the problem. This is my core belief. So if someone has a peanut allergy, they just have to find the right doctor who is gung-ho enough to get them desensitized. Yeah, it's written there. But the end result may be incredible. Same thing with anything else that you face in life. There's always a solution. Just have to be willing to open your eyes and look.
Thank you.
This immunotherapy is available for only allergy, or it's can be applicable to autoimmune disorders like rheumatoid arthritis?
So as of now, the immunotherapy that I am presenting is only applicable to allergic diseases. This is a desensitization protocol. To the best of my knowledge, there is no such therapy or protocol available for autoimmune diseases. But you all have all heard about immunotherapy that's going on for cancers these days, right? A concept that's very old and ancient. Take your own cells, prepare them, put them back, they'll kill your cancers because parts of them that are supposed to work right are not working right. So you never know, tomorrow when we get the right targets for the autoimmune disease, and I am a big believer again in that also, we will eventually find something that we could do that would modify. It's all about switching. There are switches. The human genome is incredibly wide and it has all these little checks and balances. If you find the right switch for an autoimmune disease, immunotherapy could be done for it in the future. But as of now, this immunotherapy that I'm presenting only for allergies.
Thank you.
I'm just trying to understand better who decides on which patient to get which immunotherapy, or a patient should be put on immunotherapy. From the chat we had before, there are only 150 allergists in the country. Okay, and these are the only people, if I know right, the only doctors that would treat with immunotherapy. So how does the patient go? So the patient goes to his GP, his family doctor, gets diagnosed, and then gets referred to an allergist. Is there enough education? Is there enough awareness at this level to refer this patient to an allergist?
A very, very important point, and the answer is no. Awareness about allergies is still at a very, very basic level all over the country for the most part. Only the physicians who've been exposed, or the people who've been exposed to either an individual experience or a family or a friend and understand the disease, really know that this exists. Means when I came back from the US in 2011 to my hometown of Mumbai, and I started talking to my own friends who are good physicians at good hospitals, they had no clue what I could do as an allergist immunologist. They said, what? Allergies is such a small problem. That is all you do in your life, only allergies. And it was funny because some of their own family members had to come to me a few months or a year or two later when they realized that the problem was not as small as they thought it was. And so the answer is the awareness amongst physicians is very low. I go and speak to general physicians. I've spoken at IMA, at the pediatric conferences. I've spoken at conferences with ENT physicians, with chest physicians. First, many of them don't even know that you can test for allergies correctly, because what they've been exposed to was not very good, not very accurate in the past. The ones who know that you can be tested believe that what's the big deal, so I'm allergic to dust mites, what do I do about it? It's everywhere, right? So don't do it only, don't test only. We'll just give medicines and control. That's the second attitude. So lack of awareness about the disease, lack of awareness that there exists a therapy, and then immunotherapy comes at the last stage where if the person knows, then they refer to a referring allergist. When I was sharing the numbers with you, if there are about 500 to 600 people who use the word allergist with their name, out of them 150 are full-time allergists, the others are either ENT specialists or chest physicians or whatever else. Some of them do immunotherapy, but I would say that the number of doctors doing immunotherapy in India is still a very small, countable number. And so a patient literally, I'm not joking, I'm not saying this in a funny way, but a person has to be lucky, literally in today's day and age, to reach someone who can do immunotherapy and do it correctly. There are a lot of people who are doing incorrect immunotherapy in India, even amongst those 150 people. Like they will put pigeon droppings and pigeon feathers along with dust mite and mold all into one bottle, which should never ever be mixed together. Two of them are not even proven allergens to work in desensitization. You will not believe this, but though I have been practicing now for 5 years, my largest volume of patient referral is word of mouth. It's not through general physicians, primary care physicians, or chest physicians, or ENT or gastroenterologists. It is from patients who are searching on the internet, literally putting in their symptoms, figuring out they have allergies, then searching in allergy specialist or immunology specialist, and then they find me on the internet, get my address or a number that I've put up there, call me and then come and see me. We need to do more and more awareness campaigns, programs for physicians first, and then for the general public. Because the general public is suffering, so they're going to look, they're going to do their part. But if the physicians get that awareness that there is a test available that's accurate, that there is a treatment after the test that's available, then they'll be interested in taking this forward and actually offering it to their patients. Right now, they are like, okay, there's a problem, you take this medicine for a while, when you're better, they don't go and see the physician again. Patients here don't have the concept of allergies are a chronic disease, asthma is a chronic disease, but people treat it episodically like I presented in that slide. So awareness amongst doctors about how to give the medications, how to talk to the patients. Patients to think about that this disease is not just a cold I'm getting or a sinus problem like I'm being told. So small number of people doing it, a very limited chain of referral that's happening. And so there are many barriers, as I would say, but I certainly partner with a lot of people across India and around the world for that matter, where we share our expertise with them, we give them our advice, and we are open to their referrals coming to us. And I have trusted pediatricians who send me 10 cases every week, and then I have a bunch of pediatricians who think of me once in 6 months, whereas they are seeing allergy and asthma every single day in their practice. I have done programs with Vivek at the last Respicon conference of the Indian Academy of Pediatrics, IAP, where the main convening chair stood up and said, but most allergies can be managed with medications. Why do we even need immunotherapy? And my answer to them was, if there is a treatment that can free your patient from a disease for the rest of their life, isn't it our duty at least to offer it to them one time and let them be the ones who reject it? He had no answer. The debate ended there.
I think the message is whether it's symptomatic treatment or a cure, or at least managing. If it's not full-fledged cure, it's managing disease in a proper way.
Much better.
I think this is the message that should go to physicians and to the general public.
After the diagnosis, what kind of medication is provided? Is it oral medication or injectables sort of thing? And
it's generally oral. topical, like a nasal spray or an inhaled medication, a dry powder or something, depending on the location of the disease, or a topical medication if it's eczema with an oral. It's generally an oral with an inhaled or oral with an application. It's just depends on what the disease is. Sometimes it's just avoidance. Like for a food allergy, sometimes avoidance is all you need. You don't need anything other than that.
Okay.
And then immunotherapy comes at a later stage. Once you have known the patient, know what their goals and targets are, then it comes in.
Okay.
And these medications, I have patients who are for one reason or the other not able to do immunotherapy or don't want to do it, who are on medications. Means I see them at some point as evaluating them as the fourth or fifth physician seeing them, who've been on medications for 20 years, 30 years, 40 years. They're on the medications and they're controlled. They're living their life. Means I had people who've won medals in the Olympics who had full-blown asthma, who used to take their medications on the right time, and they were competing at the highest level of competition in the world and winning medals and coming. So even with medications, you can have fairly good quality of life. But we are talking about cure versus just controlling. And that's where immunotherapy comes in.
The protocol of getting the cure is desensitizing the patient. How do you evaluate a person is desensitized to the whole?
So you're saying what is the end point of the treatment is what you're
Yes.
asking? Okay. So there are 2-3 ways that this can be done. The first and the commonest way that most physicians do it is when the patient themselves have figured out, and the doctor has figured out, that they are not requiring their medications, especially their rescue or emergency medicines anymore, and their daily requirement of medications has reduced tremendously, where they are, if they were on a controller therapy every day, they suddenly stop taking their medicine and they realize their symptoms didn't come back. Okay, so that's called a subjective assessment. Less flare-ups, less medications, less seasonal exacerbations, etc., etc., etc. The second thing that we can do is we can actually do something called specific IgE testing. It's a blood-based test where we can demonstrate that there's a decline progressively in the level of allergies as time goes by with the immunotherapy. Because skin test never becomes positive, ever. You continue to have a positive skin test even after you're totally desensitized and you have no symptoms. And that's why I told in the beginning of my lecture that being sensitized, which means having a positive skin test, and actually having an allergy where you get symptomatic with that because of that skin test agent, are two different things. So you may continue to have sensitization your whole life even after immunotherapy, but your allergy is gone, which is your overreactive clinical symptoms are gone.
With sun allergy, because there are people who get sun allergy too.
This is actually outside the purview of this topic because we are talking about something called solar urticaria. Urticaria is a whole different animal by itself. But you have to see a specialist for this thing, in short. Okay, regular antihistamines are not going to do the whole thing. And solar urticaria, I have found, has much better ancient therapies than modern therapies. Because the imbalance, and I'm going purely into alternative therapy now, does everyone know about something called the solar plexus in our body? What they call the fire in our body? Okay, when that fire is imbalanced with that fire which is driving all of us every day, that's when you get solar urticaria. So you can imagine where the therapy will be. But medications can control it and avoidance can control it. Which means, imagine if you see a guy carrying an umbrella in summer and walking around, people assume that he has solar urticaria. It's a joke, don't take it seriously. But there are therapies, there are ways to cure it, there are ways to, there is no desensitization protocol to solar urticaria. You have to work on the root cause and it can be taken care of. And medications can provide some relief.
Final question is, the immunotherapy that is in injectable format, do you have a process in just a guest format or a flow chart? How is this allergen, let's say, purified and made and processed?
So I think your colleagues here from Allergo Pharma will, it's a very, very good, well-defined process that goes from the entire mite's body all the way to just a liquid, initially a solid and then a liquid formulation that has nothing but the allergens, the proteins in it. Everything is sterile, clear, clean. Means if you looked at the fluid after it was formed, you wouldn't even know that there was anything in it. You would think it's just water, but it's very expensive water.
So it's the cytokines, is it? I'm asking.
No cytokines. Cytokines is something that we produce in our bodies. What we are seeing there are purified proteins. So they are purified proteins of the body of the dust mite that are there in that solution. That I can tell you what is in there. Cytokines is what we release in our body when we are having an immune mechanism or a reaction. So for example, the cytokine interferon gamma, IL-10, IL-12 are the Th1 cytokines which are produced in the body with immunotherapy. Whereas when you get the allergic reaction, you are producing IL-2, IL-4, IL-6, IL-13, IL-5. So that cytokine switching is what occurs in the body as a consequence of immunotherapy. In the immunotherapy, there is no cytokines. It's just what you are allergic to, simple. So if you are allergic to pollen, there's pollen in there. An extract of it, not the pollen itself. You won't see pollen floating there. If you're allergic to cockroach, you won't see a cockroach in the bottle. You'll just see a dirty looking brown fluid. If you're allergic to cat or dog, you're not going to see little fur and little nothing. It's just a clear liquid. It's the proteins that you're allergic to. And that's all that's in there. I'm making it funny, but it's a very intricate science. The people who did it first in 1911 would really just take the pollen, crush it, purify it through 2-3 filtration systems they had and would inject it. Means anaphylaxis was rampant at that time when they used to do it, because they didn't know the dosing, they didn't know many things about it. But it's gotten much better over time. We know how many micrograms will produce a good reaction, how many micrograms is too much. To that level we know now about at least the standardized allergens, 10 or 12 of them. Again, thank you very much. Thanks to Allergo Pharma for inviting me.